I am a health economist by profession, and I work for a project called Human Resources for Health, and it's implemented by IntraHealth International, which is actually headquartered in the US. We have been in this country for more than 30 years now, and our mandate is to strengthen the health workforce performance for improved health outcomes. So in this case, we look at the health workforce, including the systems in which they work. And our role, one, is to ensure that our health workforce, which includes the nurses, are accessible. They are available, both in terms of number and quality. They are connected, so we look at the digital solution, and also to make sure that the nurses, including other health workers, work in a safe environment. So we have to make sure that as nurses, you are available, you are accessible, you are well connected, and you are safe. So when I was asked to come and make a presentation, I felt that what I needed to do was to look at some of the hard facts with respect to the nurses. And most of my examples are going to come from Kenya. And of course, they could be adopted elsewhere. So as we are all aware, health sector requires adequate, well-trained, knowledgeable, and competent and equitably distributed human resources services. And they have to be of the right cadre mix, and they have to be fit for purpose. They must be market ready. So as we are talking about the universal health coverage, it is critical that we promote primary and preventive health care. And here is where the nurses and the community health workforce come in handy. They are the ones who are actually on the front line. So it is a huge responsibility to be able to create a pool of nurse workforce. One is in terms of the numbers. Two is in terms of the knowledge. Three is in terms of the skills. And lastly, in terms of the competencies. So that is very, very critical. And at this point, we need to think as nurses whether we are employees or we are a workforce. There's a difference between an employee and a workforce. An employee is one who goes to work at 8, leave at 5, and is waiting for the salary. That's an employee. A workforce is organized. It has a command. It has a plan in terms of the way they do their things. So one thing that I would like us to start off with is, let's look at ourselves, nurses, as a workforce, not as employees who go to work to look for money. And I think we did mention a few of that. So if you look at any of the countries in East, Central, and Southern Africa, then nurses will actually form a bulk of the health workforce. In Kenya, for example, at devolution in 2014, we had a workforce of about 46,000, and by 2018, this has actually grown to about 66,000, and as we talk now, I think we have added another 10,000. So there has been a gradual increase in the total workforce at this particular point. Now, if we look at the public sector, we find that bulk of the employees are actually nurses, and that is about 27,000, out of a total population of about 60,000. Now, how are the nurses actually distributed? That graph that we have really shows the distribution. And what you can see there is that bulk of the distribution of the nurses are from the primary level up to level 4. That's where you really have bulk of the distribution. And as we can see, most of them are in level 4. And bulk, about 75% are actually female. So we have about 74% female nurses and about 25% of the male nurses. So that's more or less the distribution that we have in Kenya. Again, in terms of new recruits, what that graph really shows is that in terms of new recruitment, 36% of them have actually been nurses. And this really shows the significance of that. Over time, that's from 2013 to 2019. Now that graph shows that we have an aging public sector health workforce, with the majority of them, well, if you look at the numbers from 43, but it's skewed towards the aging. Now this has several policy implications. If you have an aging population, and in this case we have an aging health workforce, the issue that comes to us is how do you make use of this aging workforce as you try to recruit new ones. And if we look at it from the context of universal health coverage, we are going to have more nurses being on the other side. We know the longevity has actually increased. And what we need to start thinking about is how can this workforce be used for referrals? These are resources at the community level. They understand the dynamics of the communities, and they have got the skills. And we normally say that you are retired, but you are not tired. So it is the point at the policy level that we need to see how to make best use of this resource. With the universal health coverage, the issue of promoting health-seeking behavior is going to be critical. The nurses are there. Issues of referrals to the nearest, to the formal system, the nurses are actually there. Issues of mentorship. How can we make best use of this resource to mentor the younger ones? The nurses are actually there. So what we can see is that if we want to shift our orientation towards a health orientation as opposed to disease orientation, that the nurses are actually there to be able to spearhead. They are there to be able to provide that stewardship. So what you can actually see as we move along is we have an aging workforce. So that's going to be critical for the work planning or the planning that we have, and we really need to see how to make best use of this resource. Now, as part of the work that we do, we normally do what is called staff audits. And this is just an example of one of the counties in Kenya, where we actually did a staff audit by level. And what you can see here is that, and this mirrors what we have, in the entire country. There's still a huge gap in terms of the requirements for universal health coverage. And this is actually just one of them for Kiambu. And what you can see for Kiambu here is that the biggest gap is actually in the level, that's level 4. Now, a further audit shows that the huge gap, or the highest gap, is in the category of enrolled nurses. And something that is also coming up as we talk now, we tend to have more of nurses with the basic degrees as opposed to specialists. And therefore, as we move forward, we really need to see how do we strengthen this component of the specialist. Those who can work in the theaters, those who can work in these other places. So that's something that is important, and we really need to see how to to bridge that gap. So when I looked at the nursing health workforce, then one question that came as, what are these critical things that we need to change? What are these critical things that we need to consider for us to be able to have a highly motivated nursing health workforce? And they are there. The first one is we have to address the issues of efficiency. And efficiency in this case is looked at from a technical point of view and also from an allocative point of view. The allocative is actually how you allocate resources. Allocative comes from allocation, the way you actually allocate resources. So you may decide to see what to put in wages and what to put in non-wages. That's more or less in allocation. Technical, you may need to look at the combination of the nurses vis-a-vis the other cadres. You really need to have that optimal combination for them to be able to work. So one of the areas that we need to look at is, what are these major causes of inefficiency? We need to look at how to motivate our nurses. We need to make sure that the nurses don't go through the problems we have when it comes to strikes. We need to make sure that nurses are considered in budgets, political interference, and in leadership positions. So I'm going to take each one of these, and it's just meant to promote our discussions. Now, for those of you who are familiar with the WHO within studies, that's a world indicator, a staff needs assessment, is actually a measurement of the workload in terms of what the other cadres are actually going through. Now, what we find is that we do have health workforce, and especially the nurses who form bulk of the workforce, are actually overloaded. That is a fact. And we also find that absenteeism is also a critical issue that we need to take into account. And in the studies that we did recently of about 7 counties, we found that absenteeism accounts for 30%. If we add those who are absent from their duty stations because of going for trainings, we have people who perpetually go for trainings and workshops, but not this one. So if you add those, you actually find that it's about 57%. Now, that is something that we really need to look at from the various countries that we come in. How do we actually address these issues of absenteeism? Now, there's one where somebody brings the jacket and you see the guy at lunchtime, and before you realize the guy is gone. But there's also the one who comes and the next week is another training, the other one is another training. And here is where we introduce more trainings. E-learning is very, very important. And mentorship and coaching and on-the-job training as opposed to face-to-face training. So there needs to be that orientation in terms of the capacity building initiatives that we are thinking about. Now, we also have cases where we actually refer our patients unnecessarily. In our facilities, do you know of examples where you have referred somebody because there's no blood? Just blood. We also have cases where you actually refer people because there's no water, because the electricity is not working. So you are looking at the life of the patient, so you feel that you just refer the person. And you are referring the person 150 kilometers away because you don't have blood. And around you, people have blood. So these issues of unnecessary referrals are some of the issues that make our workforce, and especially the nurses, unproductive. Because you cannot actually work in such an environment. When we did our studies, we found that in some cases, patients were being referred because there's no food. how are we going to keep them? So we need to take them. It's like we are transferring the burden to other people. So we need to look at those specific issues. And in one of the studies that we actually did, and this was actually in Migori, what we actually found is that as we have the universal health coverage, we expect more and more patients to come in because people perceive it to be free services. Now, there are even people who come to be able to get drugs to use the next day. So you have unnecessarily demand for services whenever you have universal health coverage. And that is why in the old system, like in Kenya, the fee was actually introduced. So it is important for us to understand even why is it important to put some fee. When you put a fee to a service, you think twice before you go for the service, isn't it? Sina hiyo shilingi 100, I don't have that 100 bob. But what happens when it is free? It's free for everybody. And therefore, if you look at the old structure, the old referral structure, for example, in Kenya and many of these countries, there was a fee. So at the lower level, it was free. And that's where you promote preventive and primary health care. When you go to the next level, it could be 100 shillings. When you go to the next level, it could be 200. So as you go upwards, with the level of investments increasing, the fee is graduated. So this actually helps from an economics perspective in terms of making decisions. So let's not just discount the fee. The fee is not meant to be a barrier, but the fee helps in terms of providing the service that we actually need. Now, we did a study in terms of the workload, and what that figure really shows is that the health workforce was overloaded for immunizations, followed by family planning, and ANC and PNT clinics. Now, this is very, very important in that the way we actually distribute our health workforce, and especially the nurses, many of them are taken to the higher levels. Now, they are taken to the higher levels where workload, now when the workforce is distributed, is now less. And those ones who are in the levels 1, 2, remain with bulk of the workload. And therefore, it is important when we do an analysis in terms of the workload to ensure that we have an equitable distribution. And there's a difference between equitable and equal. You need to understand the difference. Equal is 10, 10, 10, 10. Equitable is actually based on need. So in our case, our strategy, our policy should be that more nurses, and if you want to attain the universal health coverage, more nurses, more health workers should actually be deployed where work is. And for UHC, work is at the community. Work is at level 2. Work is at level 3. And what we are doing is we are preventing the patients from coming to hospital. And some of the things which take people to hospital, like cholera. Do you have to wait for somebody to take water which is not clean so that you now start referring the person 200 kilometers? Just cutting grass, the drainage. So, for universal health coverage, the principle is to become a health-oriented nation as opposed to, what's the opposite? We need to be health-oriented instead of disease-oriented. So let's not wait for people to come to hospital so that we can figure out how many doctors, how many specialists. And here is where we actually have a critical role for the nurses. Now then, there comes an issue about incentives. How many of your bosses have ever told you, hey, thank you? Even your patients. You are struggling with a patient there, and then what happens at the end? And even in Kenya, we have had cases where even the patients have started now beating the nurses and even the health staff. So the issue about appreciation is very, very important. And for the policymakers who are here, that is something which is very, very critical if we want to have a good environment. We have good practices in Kenya where we do have housing mortgage schemes for health workers, and that includes the nurses. We do have organizations that even provide car loans. Won't we also be happy to have our nurses driving? Why can't we just organize something for them? What about pension schemes? Each and every one of us is a health worker and is critical. But are we really thinking about our future? A nurse is as important as any health worker, and they also need to think about their future. They also need to think about their kids. As I'm talking about an aging population, they need to think about what happens after my retirement. And therefore, issues of incentives is very, very critical. If you go to our facilities, some nurses actually stay in pathetic quarters. What if we just gave it, we work with the private sector just to do a painting? It won't cost much. Or the nurses, we don't want to stay in nice places. So let's actually look at the quarters. We also have, we are in health. And let's reflect back where we come from. How many facilities have hand washing machines? Think of your workstations. Even the sensitizer. So you are going out there to talk about hand washing, and in your own facility, you don't have a hand washing. Dr. Soti, we have some at the Ministry of Health. You can't miss. Now that's the direction that we need to have. What about baby care? We are at the parliament talking about having a lactation room. At our own facilities, do we have that? And we are nurses. Let's look at our facilities. And we have seen that most of the nurses are ladies, isn't it? Do we ever mind how our nurses walk from point X to point Y? Do we have street lights? And we know ladies and security. Not that men are better, but we know the difference. So issues of like a street light. In Kenya, we have, for example, in Turkana, when they were actually facing a problem of the health workforce, they actually provided transport for their staff to be coming back to Nairobi to see their families. So weekend they can come see their families and they go back. So transport is very, very important. Now this is a digital era. And we are talking about technology being very, very key. And we would want the nurses even to participate more in telemedicine. What type of phones do we have? Can we send a message? What do we call those? So the most important thing on this slide is if we want to have a motivated health workforce, if we want to have motivated nurses, then one thing that we need to consider are the incentives. That's all that we are saying in that one. Now for the next one is actually industrial unrest, and this is something that has been key in this country. Now those who bear the brunt of health worker strikes are actually the nurses. They are the majority, and they are the ones who have a feeling that they're closest to the patients. And therefore, in this case, let's look at some of the causes of industrial unrest. One is delayed salaries. Now, what happens if somebody delays you the salary even for 3 months? And they expect you to go at work at 7. Now, your child who was supposed to go to school is also with you. And they ask, Mommy, Daddy, what's happening today? Simple things, delayed salaries. And like I know in Kenya now, I think we may expect some strikes. Now that the treasury is not giving money to the county, and therefore the county cannot give money to. So those are things that we need to look at, in terms of the delays. And how often do we sit together as an employee and employer to talk? Is it one way, go to work? You cannot ask, what about my salary? I told you, you do what? Go to work. So in Kenya, we have actually initiated through the Human Resources for Health what is actually called work councils. And these work councils is where the employee and the employer have dialogue, regular dialogue, to be able to address the issues before they blow up. And here, what we are actually doing is having a mitigation effect. And what would encourage each and every country is to have the employer on one side and the employee on the other side to have regular meetings. And what I can tell you, some of these things that cause strikes, they can actually be addressed much earlier. I can give an example. People go on strike because somebody has not been promoted for 15 years. Now, when you go deeply, what we are finding is that in some of the places, the human resource person did not know the procedure of effecting a promotion, even making sure that there's an establishment, making sure that there's budget for it. So that issue about regular consultations through work councils is very, very important. And something that we have found which causes strike is an agreement between the employer and the employee. We sit and we agree and say, okay, fine, give me 6 months, give me 9 months, and I will sort you out. So what happens? The nurses and the workforce, they go back to work. What happens after 6-9 months? They say the situation has changed. This government is different. We never talked with you. Now, a system is a system. So the issue about the CBA agreements that we put together, please, let's make sure that we honor them. So one of the things that we would like to have is to address the issue about the industrial unrest. We are currently working with the government to have what's called a minimum service agreement, because we do understand that in so much as the health workers and nurses have got their rights, in the new constitution of Kenya, the patient also has their right. And therefore, what we are doing now is currently working with the government. We are working with the various union leaders to be able to have a comprehensive agreement in terms of the minimum service agreement, so that even if there's a strike, the health workers are at least providing some service. It's absurd if somebody has an accident, is brought to you and say, no, I cannot touch because I'm on strike. So we are trying to see how to have that balance. We are also having discussions with the various unions, training them in terms of leadership, management, and governance so that they can better negotiate. And I think, as you have seen most recently, the strikes have gone down. And this is because the leaders now understand more in terms of what it takes to be able to negotiate, to be able to bargain. Of course, I think this one we talked about. Now, there are certain budgetary issues that touch on the health workforce. We did talk about the delayed disbursement, which affects us. Now, we also have cases where money is collected at the health facilities and is not brought back to the facilities. Now that is a source of demotivation for the staff, because the main idea of raising revenue is to be able to plow back part of that revenue so that it can actually be used as incentives. Now, in the former cost sharing in this country, that money that was plowed back, it was called Facility Improvement Fund. It was used for basic things like providing tea, coffee, snacks, cleaning the place, just doing small things. So that's something which is very, very critical. And what some counties are doing in this country now is to ring fence that money which is collected so that it is not sent out of health but is brought back to the health facilities. So where we actually collected that money, let's make sure that that money actually comes back. Now something else that we were doing, and I think we started off, you talked about ghost workers and all that. Now, Human Resources for Health has got a solution. And we work in the countries where you are in. We have got a software which is called Human Resource Information System. Now, one part of this software is to give you the actual numbers of staff that you have, where they are, the gender, everything from that perspective. Now, we have another component of this Human Resource Information System, and that gives you the regulatory aspects. So, on the one hand, we say Wasunna is a nurse, is in Kisumu, is 70 years old. The other side gives my qualifications, and that has to be approved by the respective profession. So when you link these two, it tells you whether that's a ghost worker or not a ghost worker. But many of these ghost workers we are talking about, they're actually brought in with the system. Somebody wants to give a relative some job, and they know that the nurses is the most lucrative, so they put their numbers there. By the time this person is not able to work, they now transfer them to do other duties. But by that time, they go with their salary, isn't it? So those are things that we need to look at. So the point here is that there are some of these things that we actually need to work on. Now, we did work with Mombasa, our county council, and we just found that there was a disconnect between those who are actually working and those who are on payroll. So when we cleaned up, Mombasa had a savings of 253 million shillings. And that was now used to be able to recruit people, to recruit staff. So it is important for those of you who come from Kenya in your own counties to be able to ask for that support. On the one hand is who is there, and on the other hand, in terms of who is being paid. So that's something that we also support the counties to do. We have gone to certain counties and they have given us, we have told them who is on our list. But when we ask them to share with us whom they are paying, they say that is with finance, that's confidential. Now, if you are that type of county, then we can't help you. But if you really want to be assisted, we'll tell you who the health workforce is, because we have them in the system. And actually, each one of you who is a nurse in Kenya, we have your database. We are the ones who have your database. So, if each county can tell us whom they are paying, then we can harmonize. But what I can tell you is that some of them, you start talking about that, they tell you, no, you are just into health. And this is government information. And you know, this is the Minister of Finance. We have nothing to do with the Minister of Health. Okay? Yeah. So that's what you get. Yes, political interference. I think all of us face this. And we do have cases where politicians go to health facilities and they denounce staff. Have you faced this? That is a source of demotivation we need to work with. We have had cases where the public service boards that are meant to recruit they normally have a lot of delays. Yet, there are certain cadres that can be delegated to others. So that's also somewhere where we need to work on. And I think in Kenya we have got the 30% rule, which means that allows the county to get people from other places. That is something that we need to look at, and it has been abused in many of the places. And we often find who knows who agenda, even when it includes deployment. Now, the last thing that we need to look at, and this touches on all the nurses, I think, is what opportunities are there for nurses to rise to leadership positions. I think that's something that we need to look into. And one of the points is that the societal and cultural perceptions about specific roles of women and men provide a main barrier, and especially for the women to actually go to the leadership. We also have cases where, even within the nurses, when you consider the males and females, the males would be considered more for promotion than actually the females. And then there's an issue about women being taken, doing nursing as a part-time job. When you actually look at how to manage both work and home life, that gives a critical issue. So the issues of women actually, not women, but nurses getting into leadership is something that we really need to look into. So as we actually move on, I think some of the key takeaway messages, one is for us to be able to support the nurses to undertake the leadership courses and attain positions that are critical to the Nursing Now campaign. We also need to ensure that we have effective deployment of this key human workforce. And most critical, we also need to ensure that we actually have adequate data that we can actually use for decision making. So as we move forward, my parting shot is that if we want to succeed in the universal health coverage, then the most critical resource that we need to look into is the nurses, and by extension, the community health workforce, where the nurses will also play a critical role. If we move in this direction, then we are going to move our countries and counties towards more health orientation and move away from the disease orientation. So to all the nurses, kudos for the great job that you are doing. And Elizabeth, I know you have actually been in the front line. Don't give up. And Dr. Soti, we need you at the policy level to help us to govern many of these things. So with that, thanks very much.